Shaneyfelt is a gastroenterologist at Bozeman Deaconess GI Clinic, and we are very happy to have him here today talking about treatment approaches in inflammatory bowel disease. So thank you all for being here, and thank you, Dr. Shaneyfelt.
Well, it's my pleasure to be here, and appreciate everyone coming out MSU football Saturday. I'm going to be using the CCFA program that they have, but I am very open to questions at any time along the presentation. So if someone has a question, just raise their hands, yell out, shout, get my attention somehow, and I'll try to address that question. Oftentimes, 10 minutes into the talk, people start kind of zing off, and if you kind of ask questions, I think it helps to keep you awake. So if you're awake, you're going to retain and hopefully remember some of the things that are said. They do have just several kind of questions, which on the face kind of go, they're actually a little bit tricky, but not that bad. But the pre-programmed questions they have for this are: which medications for inflammatory bowel disease are genetically engineered and interfere with the body's inflammatory process? And that's aminosalicylates, those are the azacols of the world, biologics, the anti-tumor necrosis factor alphas, corticosteroids, and antibiotics. Question 2 is: what neurologic changes, or what are neurologic changes in bone loss or possible side effects associated with which medications for inflammatory bowel disease? And which of the following medications is prescribed for moderate to severe active disease but has an increased risk for infection? And finally, treatment adherence in inflammatory bowel disease associated with which of the following outcomes? Again, I want to touch on the similarities and differences between Crohn's disease and ulcerative colitis. They're distinct entities, but there is overlap between the two. I'll talk on that. And specifically drilling down on the risk benefits of different medication surgery and kind of just complementary approaches to inflammatory bowel disease, which I feel can be very, very helpful. And also just how one can kind of manage this disease. You have to be a willing participant and take part in your disease process if you have inflammatory bowel disease. And the more you know, the better you're going to be in terms of your long-term health. It's critical to understand these diseases and disorders. And if you have a good understanding and participate actively in your care, you're going to be a healthier, happier person in the long run. These can be devastating illnesses, and education is key and critical. And also just adherence to treatment plans and why we want people to stay on these medications, why we use the different medications that we use. And this is a team effort. And in my office, my nurse Kayla is very key and critical in communicating with my patients. Hearing from people if there are problems is important for patients to communicate with their healthcare providers earlier on in the course of flares, because once a fire started in the house, it's hard to get it out. When it's just kind of in the kitchen on the the gas range, it's a lot easier to take care of with the fire extinguisher rather than the Central Valley District coming to pour water on your house. More than 1.4 million Americans currently living with inflammatory bowel disease. My sense is that there are just more people who have inflammatory bowel disease as we go forward in life. These are diseases primarily of post-industrial societies. We don't know exactly why that is, but it probably ties into kind of the underpinnings of what's happening with inflammatory bowel disease. And they're unique to each individual. There are characteristics between different individuals, but everyone has a different kind of journey with their experience with inflammatory bowel disease. And as a result, treatment approaches vary on the type of disease and how it affects you, and also kind of what you feel most comfortable with as a patient. Inflammatory bowel disease is not irritable bowel syndrome. They're not allergies. It's not an immune deficiency. Irritable bowel syndrome is a distinct clinical entity, which many patients think that we kind of label them with when we don't know what's going on with them. It's a syndrome. Many patients who have irritable bowel syndrome, or many patients who have inflammatory bowel disease, have irritable bowel syndrome as well. And those type of patients can drive us as doctors nuts because you don't know what's causing what. Irritable bowel is diarrhea or constipation associated with an element of abdominal pain, so there can be overlap in terms of the symptoms, but they're distinct clinical entities. And I think it's very important to realize that with irritable bowel disease, there's no inflammatory component, at least on the interface, which is occurring within the small intestine and the colon. There is probably a low-grade inflammatory process that occurs in the deeper levels where the nerves and the muscles occur that is not measurable in irritable bowel syndrome. It's an actual disorder of inflammation, but it's a very subtle inflammatory change. It's not measurable. It's not seen on the biopsies that we take for patients who have IBS. But inflammatory bowel disease can kind of set off IBS as well. The other thing is this is a chronic series of illnesses, and chronicity defines the illnesses themselves. I always get these phone calls on the weekend from the emergency room saying, I've got this 23-year-old person who's come into the emergency room and saying 2 days of abdominal pain. Everyone gets a CT scan when they go into the emergency room, whether they want it or not. And they have inflammatory changes in their terminal ileum or their ascending colon, and they're saying, you got to come in and colonoscope this guy. They've got Crohn's disease or whatever, and they say, no, they don't. They've got an abnormal imaging. They probably have an acute illness, and time will tell whether or not this is, in fact, inflammatory bowel disease. Usually patients who present with symptoms have had problems for a period of time, and in most circumstances has been there for a very long period of time, and it's been subclinical with actual inflammation that may not always have been clinically apparent, or in retrospect becomes a little bit more apparent that something had been going on. These diseases are treatable. In many cases, there's a genetic predisposition. I have one family here in town where the father ended up having severe Crohn's disease, almost died of his illness, and 2 of his daughters have severe Crohn's disease and have had ileal resections. So there's this genetic underpinning that kind of makes you more susceptible to either one of these diseases. There's this immune system abnormalities, and once this gets going, it's basically, I think of them as being autoimmune disorders, but you have to kind of think in terms of what is immunity, and I have a very simplistic approach to immunity. And that is that there are 2 basic forms of immune response within your body. One is what's called innate immunity, and that's basically, someone sneezes on you, a virus gets into contact with your mucosal membranes. You have no memory or immune memory that kind of can deal with this organism, but your body recognizes it as being something bad, and it will generate different things such as interferon to try to stop it in its tracks, but it's not targeted towards that organism specifically. Crohn's disease is essentially a disease of innate immunity, at least initially. Once it gets going, there's what's called adaptive immunity that kicks in as well. And ulcerative colitis is a disease of adaptive immunity. It's actually more immunoglobulin driven. It's more kind of higher levels of antibodies. And that's why Crohn's disease, you'll see more issues with anti-tumor necrosis factor alpha. The biologics are more effective. And then ulcerative colitis, when you direct against the immune system and with your immunosuppressants, generally you're going to have a little bit more long-term benefit in those diseases. Again, there's overlap between adaptive and innate immunity, but the initial process that occurs that causes these diseases to get started has a difference. There's an ultimate difference in terms of how things are going. Environmental factors are huge, and we're starting to just understand those environmental factors. A lot of these disorders, you may have a genetic predisposition, and there may be an infection that triggers a specific immune response. And once that immune response gets going, it can't stop. It keeps going, and it can cause ongoing inflammatory process, and in turn, chronicity. Antibiotics are very interesting. From my perspective and my spiel is, 60, 70, 80 years ago, we ended up developing these antibiotics which revolutionized the treatment of pathogenic diseases, invasive organisms, and all of a sudden people were dying from staph infections and this and that. We're living. But I think that we didn't recognize the importance that we live in a microbial world. We swim in a sea of microbes, and you never get away from them. And 99.999% of those microbes are actually, they're not harmful. In fact, some of them may be of help and benefit. And the problem with antibiotics is that they kill off a lot of good bacteria. They also cause, many of them will cause the bacteria within your intestinal tract to rupture, at which time you get this shower of immune stimulation. And you can end up, we used to think that your microbial population would kind of bounce right back after you ended up having a broad spectrum antibiotic. And I think the recognition, and again, the expert will speak a little bit later today on this, the recognition is starting to be clear that our microbiome doesn't really always snap back as well as it should. And when you end up altering that microbial flora, and particularly when you end up kind of changing the diversity of that microbial flora, things aren't as good. And this also interplays with your overall health because you have tons of T cells or lymphocytes, which are basically controlling your intestinal tract. As I like to say, your lymphocytes, they're helper lymphocytes and suppressor lymphocytes, and they're like the Los Angeles Police Department. I may have used this one in the office basings, some of the patients in the office, where the duty is to protect and serve. But if you're Ferguson, Missouri, or you're LA County, you pull someone out, beat them up, shoot them, all hell breaks loose. And once all hell breaks loose, it's hard to get things back in balance. And we're also recognizing that antibiotic use early in life is having very negative consequences for patients later in life, which may change bacterial diversity, and it has extremely negative consequences with the long haul. Exactly how that's all going to pan out is unclear, and hopefully with help and support by CCFA and other people, we'll get some more answers. I'll put a plug in for that because the problem with looking for microbial organisms and their interaction with human diseases and health is that a lot of the research dollars in this world are driven by, research is driven by money, and there's no money to be made by the pharmaceuticals and selling kind of probiotics. So I think you have to recognize that there's some people out there scrounging for money, trying to do good work, and they're really going to be the people who lead us forward in terms of understanding these diseases and disorders and helping people in the long run. And CCFA has been very helpful in that respect. And I think you have to respect them for that. Anti-inflammatory drugs, non-steroidal anti-inflammatory drugs, in my estimation, particularly in Crohn's disease, are bad drugs. Advil, Nucrin, Aleve, they're on over the counter. The pharmaceutical companies are making money off of them. They're not evil people. They're providing a service, but they interfere with prostaglandin synthesis. And prostaglandins promote inflammation, but they have multiple other functions within the body, and most of these are non-selective. They interfere with prostaglandin synthesis non-selectively, and prostaglandins are very important for maintaining epithelial integrity within the stomach, but also within the intestinal tract. And I do colonoscopies all the time on patients who have screening procedures, and I've stopped sometimes going into the terminal ileum because I'll find 3 or 4 or 5 erosions that are there. And you go, oh, what's this? And you take biopsies, and they sometimes, they may just see an acute inflammatory response, and the pathologist comes back saying, well, this can be due to colonoscopy preparation, which is particularly true when you use phosphate-based preparations, but there also can be the non-steroidal anti-inflammatory drugs. And it's my belief, again, this is not totally proven, that there's a subset of individuals who seem to be particularly prone towards non-steroidal anti-inflammatory drugs, causing mucosal breaks within your intestinal tract. And you want to keep your intestinal tract, the biofilm, the mucus layer, intact. Because once that layer gets damaged and you get bacteria that can get into the deeper levels, then you're more likely to have immune stimulation. So I harp at people about, stay off of your non-steroidal anti-inflammatory drugs, blah, 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 blah. Diet is huge, and we don't know the answers to diet, but we've also gone amiss. If you look back towards, back into the Industrial Revolution, and basically when people lived on the farm, and they ground their wheat, and they drank beer, They had relatively few nutritional deficiencies. All of a sudden, with the onset of the Industrial Revolution and grinding wheat, taking wheat germ out of the, your flour, taking bran out of the flour, and altering the production of beer, all of a sudden they ended up having fewer micronutrients introduced into your diet. And then people like Charles Dickens, and they're also in these huge factories without any kind of sun exposure and very low levels of vitamin D. All of a sudden you have Charles Dickens writing all these horrible, kind of issues with people and nutrition and nutritionally driven diseases, with kind of the peak of them being, kind of the vitamin C and vitamin D deficiencies, rickets et al., human health and disorders occurring as a result of that. But, the food technology industry is not evil, but they're trying to feed a lot of people in this planet, and they're trying to do it cheaply, and they're trying to do it in a fast, efficient, industrial way of producing foods. And our diets are highly corn-based. They're highly, wheat-based. Wheat is basically sugar in this day and age. And it's not good for us, and it's not good for a certain subset of the population. And people who, it may, again, how it ties in, we don't know. But a lot of current human health diseases are related to the diseases or the diet that we eat. And that can include obesity, which is a huge kind of epidemic as well. Smoking is interesting. Smoking actually does two things. It will actually decrease your risk of Parkinson's disease, and it decreases your risk of developing ulcerative colitis. And some of the more challenging left-sided colitis patients I have are people who have stopped smoking in their 40s or 50s and end up getting inflammatory bowel disease, and it's horrible to treat. But otherwise, it provokes Crohn's disease. It's horrible for Crohn's disease. If you get patients who have Crohn's disease and get them to stop smoking, it really is as good as taking many drugs. Stress is a big factor. There's some people that just seem like, I had a patient in my office not too long ago. He'd gone through a divorce, remarried, blah, blah, blah. And his colitis had flared, and then, everything was better, and his colitis went down. And there's some people who just seem to have their inflammatory bowel disease as a stress, kind of a measurement. Probably having interplay with the body's immune system and that whole issue of the T cells. Again, genes that I don't understand, but I see that on a clinical basis. We'll talk about some of the other issues along the way as well, but I think it's kind of, these things are of great importance, and we need to kind of work through them as time goes on. Now, the spectrum of inflammatory bowel disease, Crohn's disease is a full thickness disease. So you have your intestinal tract. People don't think about their intestinal tract, but you have the mucosa, which is the surface, and then this small intestine, its job is essentially to absorb nutrients. 99.9% of the nutrients that you're going to absorb in your body come from your small intestine. And you have about 9 liters of fluid that kind of gets secreted and absorbed in your small intestine. There's a lot going on in there that we don't think about because we don't see it. And as humans, if you don't see it, you don't really kind of register it. Crohn's can occur anywhere from the mouth to the anal opening. It rarely affects the esophagus, rarely affects the stomach. You can get oral Crohn's, and small bowel and chronic Crohn's are where things usually end up happening. There seems to be a tendency for some people to have Crohn's disease primarily in their colon. Some people have disease primarily in their intestine, and quite a few people have kind of intestinal and chronic disease. And it's just, it's kind of a skip disorder where you'll see inflammatory changes, things will look normal, and then you'll see other inflammatory changes elsewhere. And there's a large component of perianal disease that can be associated with it as well. Because it's a full thickness disease, you can end up getting perforation of your microflora into the surrounding structures, get abscesses, develop fistulas, and these are the type of disorders that you can see with Crohn's disease. Later in its course, and all of these diseases seem to have a life, but Crohn's disease generally has more of an acute inflammatory process, and then late in its disease, it becomes more fibrotic, and there's more of a tendency for scar tissues to occur. And once that active inflammation resolves, then our people get into issues with narrowing of the intestinal tract, particularly the small intestine, and obstructive type patterns that can occur with the natural history of Crohn's disease. Nothing's written in stone. Things can be quite different, but that's kind of the tendency is for this to kind of evolve over time and over years. Ulcerative colitis is limited just to the colon and the rectum. It usually starts in the rectum, goes up a variable distance. We talk in terms of left-sided disease, and it's usually beneath the splenic flexure, which is on the left side, or pancolitis, which is anything that extends up above the splenic flexure. There's inflammation that can be limited to the rectum itself. That's proctitis. There are some people that just have the ulcerative proctitis by itself. It can be sometimes very challenging to treat. It doesn't have the risk of ever developing into cancer, but generally the colitis itself does have a definite risk of developing into a malignancy over time. And more recently, the Mayo Clinic in particular has kind of pushed forward the recognition that there is an increased risk of colon cancer with longstanding Crohn's disease as well, and they're pushing for surveillance with patients who have Crohn's disease. How much of a risk that is, I think that's open to debate. All of these can have extraintestinal manifestations because you have this inflammatory kind of blue. There's this cascade that goes into your portal vein, goes into your liver. Everything then gets processed by the liver. Again, with the ulcerative colitis, you have antibody formation. There can be immune complex formation, deposition of immune complexes, and other issues associated with that. So it has more of a robust, peripheral type of systemic extraintestinal manifestations, but they all have some degree, including arthritis, and it can be large joint arthritis. And many patients are shared between the rheumatologist and the gastroenterologist in terms of their disorders. About 10 to 15% of patients have kind of an indeterminate colitis, and that is where you'll oftentimes do this. They'll have inflammatory changes just in the colon, may have deep ulcerations. It doesn't appear to be simply mucosal, and sometimes you just can't tell for sure. On occasion, doing antibody testing can be helpful in that type of a situation. We don't do that very often. Again, the goals of management are to improve the quality of life, ensure adequate nutrition, maintain remission, control symptoms, treat inflammation, treat complications, minimize treatment toxicity, and that's huge, and provide emotional support, and that's oftentimes the family members can be particularly helpful in that respect. Understanding, and again, this is a spectrum of this inflammation where a person can be healthy. There's a period of subclinical inflammation for a long period of time. We don't quite understand exactly what's going on in that situation, but I do believe by eating healthily, avoiding non-steroidal inflammatory drugs, limiting exposure to broad-spectrum antibiotics, you probably will substantially decrease your individual risk of developing inflammatory bowel disease. And then once you get into symptoms, then you end up kind of coming to our attention, and we kind of go ahead with the things that we know and what we've been doing. This is, I think, very critical to understand, and it's kind of a treatment strategy, and this has been an argument that's been going on for a long period of time within my area of expertise or presumed expertise, and it's this issue of top-down strategy or bottom-up strategy. And the bottom-up strategy has been the approach through many, many, many years, and that is we start with the medications that don't have a lot of toxicity but aren't particularly effective in terms of how they work. And those are typically the aminosalicylates. Those drugs are essentially an aspirin-like drug. Salix is basically the genus of the willow tree. And for many years, people knew that chewing on willow bark would help with toothaches. And basically, Bayer came out with aspirin, which is acetyl salicylic acid, and this is 5-aminosalicylic acid. So it has a very close structure to aspirin with an amino group on it rather than an acetyl group.
How do these anti-inflammatory drugs differ from the others that you said can cause problems?
What other ones causing problems? The NSAIDs. Well, these interfere with leukotriene production, so they don't interfere with prostaglandin synthesis. And it's the prostaglandins that are important for maintaining epithelial and mucosal integrity. And these are leukotrienes, so they're actually working on the white blood cells, or an anti-inflammatory. It works by a different mechanism against inflammation, although they're structurally similar medications. They don't damage the mucosa where you're. And aspirin itself is interesting because aspirin has more of a direct effect on toxicity to the stomach, but it doesn't really have a lot of downstream toxicity. It's more the NSAIDs, non-steroidal anti-inflammatory drugs, that have the downstream risk of causing damage. So when patients say, I need something for headaches or whatever, I've got inflammatory bowel disease, I'll say acetaminophen. Acetaminophen has a bad rap because of its issue with potential liver toxicity. But you can take up to 2 grams of acetaminophen if you're eating reasonably well, and you'll never get a hepatotoxicity with acetaminophen. It's just not a great drug as far as inflammation, and it's only modestly effective in pain relief. But then as far as I'm concerned, most patients can use aspirin as long as it doesn't upset their stomach. But if you're on aminosalicylate, you have to be very careful because there'll be kind of combined salicylate toxicity between the two. And you generally, those are drugs that are well tolerated, but they're not particularly effective drugs. And some of them are horribly expensive. Anything branded in this day and age is just becoming absolutely crazy in terms of what you're paying for these things. You have to pay for them out of pocket. There are a few generic, kind of medications. I'll comment on those in a moment. Steroids have always been the mainstay of treatment. When I started in the 1970s with Crohn's disease, we just bomb patients with steroids. They kind of get better for a while, get sick, you bomb them again with different steroids. Then sooner or later you get steroid toxicity, and they're horrible drugs in terms of long-term toxicity. And they should only be used for short-term use. Now, there's a little newer permutation on the steroid end of things, which I'll comment on, which makes them a little bit of a more friendly, form of therapy. But people die from corticosteroid toxicity in the long run. That's the big mistake. You see these people having been out in the hinterlands, and they've been given, prednisone for years and years. They come in around 15 or 20 milligrams of prednisone. They've got stretch marks, they've got moon faces, they've got early osteopenia, arthrosis, and you have to wean them off those steroids because it's just the short-term and long-term toxicity of corticosteroids is horrible. It's awful. Then the next step up is the immune suppressors, and that's again the azathioprine, 6-mercaptan purine medications, which have their own set of issues and problems. Back in the 70s, it was Lenox Hill in New York that they were kind of pushing the 6-MPAs of azathioprine, and we were kind of as community doctors going, what? These are kind of for organ rejection and blah blah blah. The concept was really interesting, and then the data has kind of come through the years and shown that these drugs can be very helpful. All of these drugs, when we start talking about very helpful, we're talking about 60-65% of people responding. If you look at large, kind of clinical trials for the most part. And then the next step up is the biologics and the surgery. Now, your pharmacy benefit manager wants you to start with the least expensive, least, and it's not because it's the best drug for you, it's because it's, cheaper, and that's kind of basically the world we live in. Now, American College of Gastroenterology came out, I think it was in December of last year, say with Crohn's disease, and biologics are, quite effective against Crohn's disease. There was a cover for American Society, I think it's gastroenterology, I can't remember, American Society for Gastrointestinal Endoscopy, and it showed this before and after photograph. It was like in the late 1980s, and it showed ulcerative changes in the terminal ileum with deep erosions, kind of the before and after. All of a sudden these erosions were gone. It's like the light bulb went off. It was just like, wow, never seen this happen before.
What are biologics?
Those are the Remicades, the Humira, and Cimzias of the world, basically. They're the anti-TNF agents, and Andy Gentry, who's here, is going to be talking about those a little bit later. But they're drugs that revolutionized the treatment of Crohn's disease. It's like, kind of the vaccine for polio all of a sudden. But these are the drugs that all of a sudden they cost $2,000-$3,000 a month for therapy, and it's kind of like it was Abbott, now it's AbbVie. They're kind of split off, and they show all the advertisements on TV with smiling people, and then they show all of the kind of list all of the horrible side effects that can occur afterwards, including death. So, they have everything has upside, downside, and you have to kind of learn what the upside and the downside is as far as these are concerned. But the American College of Gastroenterology came back and said moderately to severe active Crohn's disease should be treated with biologics, and you kind of work your way down. And that's really the best way to end up going. But unfortunately, many of the pharmacy benefit managers won't let us use biologics as the first level of therapy. You have to fail other therapies first before you go to biologics. And the question that we're dealing with is, practicing physicians, is what defines failure and at what level can you start using biologics?
This is kind of semantics, but the pharmaceutical companies make it that the patients fail the medications. I like to think that the medications fail the patients. So I like to just change the paradigm. Who writes those rules? And it's the pharmaceuticals, because they're saying patients are failing these meds. And I think the meds are failing the patients.
Yeah, well, I think that it's dollar driven, and it's basically, it's not always what's best, what is really the best option in terms of treating people. It's how much does it cost rather than what's the best. And you have to understand, even though I say these biologics are game changers and everything else, they have their own set of side effects, and you have to be aware of those side effects, and they have to be used appropriately. And one of the things that we're finding out is it's key and critical. You just don't give a person a biologic and say, here, take this, you'll be fine. You have to end up getting patients' anti-TNF levels up and keeping them up. I think that's what we're really recognizing is so critically important, because you start feeling good and you start skipping your meds, and I don't really want to take this, I don't want to do this, and then all of a sudden your levels go down and you're back in trouble, and we have to it's the full concept of trying to reboost people and blah blah blah, and it's just very challenging. So it's an educated individual taking part in their care, understanding the importance of staying on these medications and staying on them faithfully.
I have ulcerative colitis. I've been treated for 2.5 years. The initial treatment was bottom up, and currently I am taking drugs in each one of those classes. How common is that?
It's not uncommon. From my perspective, you'll hear different things from different people. The biologics don't work as well in ulcerative colitis as they work in Crohn's disease. It's used for salvage therapy. And generally, some of these we're talking 25, 30% down to 16% rate of salvage. Combined therapy is more effective than single agent therapy. And I don't want to get into the biologics too much, but I'm a community gastroenterologist, and I kind of am a minimalist. I don't really like medications. I don't like antibiotics. I think we take too many medications as a society. But having said that, there are times when you have to take more to get things done, and the combination is more effective for that patient who has more severe disease. The downside is you have a greater risk of infections. That's the biggest issue when you start adding in these different medications. You have to be aware of those. But having said that, if you go on low-dose immunosuppressants with a biologic, you don't have as much antibody formation against the biologics. The biologics seem to work better for a longer period of time. Less risk of kind of losing effectiveness over time. So that, and again, it's just kind of this, where do we go? And those are kind of questions, and it's kind of what we feel like as doctors in terms of comfort is what the patient feels like, comfort like, or feels most comfortable in terms of doing. But if you've got bad disease, you need to be treated aggressively, and it's covering different categories of medications. And it's each individual, that's why I say it's a spectrum of illness. Many patients with ulcerative colitis will come in. You hit them hard with the valsalicide, colisol, or some other salicylate, they do well. And you might put them on a variation of steroids, and you get that inflammation down, and you tell them just take this medication, take it. And a significant percentage of people will do well with starting with that bottom up. But the more severe patients who have more severe disease probably need more of a top-down strategy. But again, I can't stress the importance of staying on the medications and also not only the medications, but it's the other things you do with your life that I believe make a huge difference in terms of these diseases and disorders. It talks about over-the-counter medications, prescription medications, surgery. Some of these we talked about, the over-the-counters, antidiarrheal agents. It's just for relief of symptoms. You don't want to take a lot of Imodium when you've got an acute flare or disease. Your body's trying to purge inflammatory, materials from your body. But someone who has chronic Crohn's disease has had partial resection of their small intestine. Those can be kind of game-changing medications in just terms of comfort. The laxatives don't really have any role in those. Pain relievers, again, NSAIDs, GI irritation. I'm particularly kind of adamant about staying away from the NSAIDs because I really do think that they contribute directly to the disease process. Antibiotics, again, antibiotics can be used in active inflammatory bowel disease. I use them very infrequently. I only use them in Crohn's disease. They have no usefulness in ulcerative colitis, and they're primarily used for patients who have perianal disease. All of the antibiotics have some degrees of issues associated with them. And again, antibiotics can sometimes cause flares of the illness by killing off bacteria and stimulating immune stimulation. Plus, the antibiotics can oftentimes allow an individual who's been kind of perking along with low-grade, say, ulcerative colitis. If you ever get C. diff on top of ulcerative colitis, watch out. It's not a good combination. I've seen patients who have had well-controlled disease for very, very many years. They get on antibiotics or they develop a C. diff superinfection, and it's like gasoline and matches. It just doesn't work very well. And I've had several patients have accelerating disease, can't control them, and end up with colectomies after 20 years of kind of just low-grade, ulcerative colitis. And you have to be very careful with those, with recognizing C. diff. The antibiotics we use are ciprofloxacin, quinolone antibiotic. I used to use Cipro for everything, and then now we recognize that one, it's probably we used to hardly ever cause C. diff. Now it's one of the most common causes of C. diff infections. Metronidazole, it's an awful drug. You can't drink alcohol with it. It causes horrible nausea. It causes birth defects in mice, but probably not in humans. Xifaxan is an interesting drug, horribly expensive, but it can be very helpful for patients who have bacterial overgrowth, and many patients, particularly post-operative patients who have small bowel disease, will eventually get bacterial overgrowth. But 7 days of Xifaxan is like $800, and your insurance company won't typically pay for it. But it's a large molecule that kills off the bad bacteria, leaves the lactobacillus and bifidobacter standing, and it can help to improve the quality of the bacteria that live in your intestinal tract, where all of these other drugs are non-selective. They kill whatever they can kill. So that's where the Xifaxan can be helpful. It's a non-systemic antibiotic, with the exception of my daughter, who recently had it for bacterial overgrowth, developed high fever, neck stiffness, and meningitis, or meningitis type symptoms. So taking it. I mean, there are some people, even though such a large molecule can get absorbed, particularly if you have intestinal permeability, and then it can cause systemic inflammation. It's like rifampin, which is used for tuberculosis. Okay, aminosalicylates. Again, these drugs can be used for induction in mild to maybe slightly moderate ulcerative colitis, and their primary goal is preventing relapses and maintaining remission in ulcerative colitis. They probably don't do a whole lot for maintaining remission in Crohn's disease. Generally well tolerated. And again, the issue is if you take 5-aminosalicylic acid, it will get absorbed in the small intestine, it won't get to the colon. So you have to kind of formulate a way to get it into your colon. And that's where a lot of the issues come here. Now the top one is valsalicide colazole. Valsalicide is generic, and it's a very large molecule. We use 750 milligrams, 3 of them 3 times a day, which is the full dose, and no one in their right mind likes to take medications that often. But valsalicide is hooked to para-aminobenzoic acid, which is a constituent of certain sunscreens. As I like to say, unless you're really strange, the sun doesn't shine up there, so you don't need para-aminobenzoic acid. But what it is a very large carrier protein, and it has a diazo bond, so it goes into the colon, bacteria cleave it, and then it releases the 5-aminosalicylic acid within the the colon. Cheap, sometimes doesn't seem to work as well as some of the other ones, make it a little bit of gas bloating. But I have gone to the point of view of just using valsalazide now from the get-go because it doesn't have sulfa in it and it's cheap. Because Azicol and Lialda are fine drugs, but if you don't have a good pharmacy benefit manager, those things are just horribly expensive. It's obscene. The same thing is true of Pentasa. Pentasa is designed to release it further upstream. I haven't used Pentasa for probably 20 years. We had some samples, we threw them out about 4 years ago, or 2 years ago, I think. They think they've been in the cabinet for I don't know how long. Priso is kind of a strange drug. It's been approved for, it's mesalamine. It's been approved for keeping people in remission. It's kind of a Me Too drug, and I don't really use that very much. Rectal suspension and Rowasa works well for left-sided disease. My experience is most people don't like enemas, and they don't like using Rowasa, but it does work as well as the steroid enemas, and it's just hard to kind of get people to kind of use those for left-sided disease. And Canasa's rectal suppository has been horribly expensive. It's like $15 for a freaking single suppository. It's nuts, so we hardly ever use Canasa. Recently, budesonide has been released for left-sided disease. It's the Euceris, which I'll talk about in just a moment. It's just been approved by the FDA, which is going to be horribly expensive. We've been using budesonide enemas in years past, but I think you can probably get formulated other ways, but it also can be very helpful. Hardly ever use dipentum, which causes diarrhea. And sulfasalazine is a good drug. It's been used for years and years and years, what we had originally. But about 15-30% of people have side effects with diarrhea, rash, or other type of problems associated with sulfasalazine. And you have to be cognizant of those facts. I always tell people, you could get a rash with this. I don't use it very often, and 9 times out of 10 when I give it to a person, they get a rash and you stop it. It seems like I select people who get rashes and decide to take the drug. But for 70% of patient population, dirt cheap, effective, and just as the sulfadiazine is the other part that's held by that diazo bond. So you get this sulfa that gets absorbed into your body. The sulfa can kind of lead to photosensitivity. It can lead to other kind of side effects. It's a sulfa medication in general terms.
So is that like an antibiotic now?
Well, it's an interesting drug because, it is an antibiotic. It's not a very effective antibiotic per se. The sulfa may have some therapeutic benefits. How much of a therapeutic benefit is unclear. The people who use the most sulfasalazine in this day are the rheumatologists. It's really interesting that they use quite a bit of sulfasalazine for patients who have different rheumatic diseases because it seems to be effective for rheumatologic diseases. In fact, how sulfasalazine came about is that back in the 1950s, after sulfa came out, basically they knew that a lot of patients had arthritis. Well, first off, there was this theory that arthritis is caused by infection. So they're basically trying to get this anti-inflammatory and an antibiotic combined to be absorbed into the body with the thought that we're going to treat this underlying arthritic condition. We'll kind of kill off whatever bug might be causing this. This is the golden age of microbiotics. And what they ended up noticing is that it wasn't particularly helpful for a lot of people who had arthritic complaints. That's systemic arthritis, synovitis. But a lot of the patients who had colitis with their arthritis, and there's overlap between the two, came out and said, my colitis is better. And it was then studied for their colitis and found that it was in fact helpful for inflammatory bowel disease. Now it's kind of the first drug that was available for treating inflammation, particularly with colitis.
Mechanism, we really don't know.
As far as
how it improves intestinal diseases. How does it reduce the inflammation or treat the Crohn's disease?
Well, it's not good for Crohn's disease in general terms. It's very relatively minimal efficacy for Crohn's. It's better for ulcerative colitis than it is for Crohn's. But it's the 5-aminosalicylic acid primarily that's beneficial as far as these drugs are concerned. The sulfadiazine may have a minor part, but we don't think of it as being a major part. It could alter the microbial flora in a good way and may have other effects. We just don't understand at this point. So I can't really answer that question for you. Now steroids, again, they're very effective. If your house is on fire, you have to pour the water on it to get the fire out. These are the drugs you use to get the kind of fire out when things are just going bad. And again, infections, psychosocial impacts, sleep disturbances, mood swings. I usually tell people that they'll be up at 2 o'clock in the morning cleaning their kitchen, wiping down the walls. They just have all this energy. They're kind of bouncing off the wall. One girl I had not too long ago had to put on steroids said that she and her family drove up to one of the lakes out of town, and she said she about drove her family nuts because she couldn't stop talking the entire way. So they really can kind of make you a little perked up and kind of odd and unusual, and you get the downside when you go off of them. Weight gain, moon phases, buffalo hump, and they can be horrible as far as rotting out your bones with osteopenia, osteoporosis, particularly long-term use. And in young kids, growth delay is a big thing. And then there's a tendency that once you go down off these drugs, there's sometimes a rebound phenomenon. And there's a high percentage of patients, once they get started on steroids, need to go back on second and third courses of steroids. That's what you want to try to not have happen. So we don't use these. We have to use these drugs periodically to get active severe inflammation under control. But the goal in current management of inflammatory bowel disease is to use these drugs very sparingly and to use them appropriately. Now, again, the steroids, I mentioned that there's budesonide, Intacort. There's another one that's not on there called Ulcerative. Intacort was released for treatment of moderately active distal terminal ileal Crohn's disease. It's a steroid. It's absorbed by the body, but it's very efficiently broken down by the liver. So very little of it gets out and causes systemic side effects. There have been a number of different studies looking for obvious evidence of adrenal suppression with this drug, and relatively infrequently, if ever, does it occur. I've had one patient that I know has had issues with it. There may be a few individuals where it will escape the liver and cause systemic side effects, but it's generally pretty well tolerated. It's now generic, so we use the generic budesonide. Even as generic, it's expensive. It releases more in the distal small bowel, proximal colon. You get a little bit in the distal colon. Sometimes I'll use it for distal disease as well. It seems to be helpful for some individuals. Ulcerative is the new 9 milligram, 1 pill a day budesonide formulation. And again, I think it's like $800 a month or something. 1,200 bucks a month. Yeah, and it's all these things where it's a very good drug. It really helps with left-sided disease. If the cost wasn't so high, we'd be using it more and more and more. But we just get up against these pharmacy benefit managers, and they say no, or people have to pay $600. It's kind of whether you eat or you end up buying the medications. It's just kind of a shame. But it's a good drug, and it can be very helpful. And if you have a good pharmacy benefit manager and you have kind of discount cards or whatever, it's a really good option rather than going on prednisone for many patients. And prednisone is kind of methylprednisolone. It just basically avoids metabolism by the liver. So Medrol and prednisone are kind of basically one and the same. Hydrocortisone enemas, we use it for left-sided disease. Works pretty well. There is some hydrocortisone that gets absorbed into the body, so it does have some systemic effects, but they're relatively minimal in relation to using prednisone. Now, immunomodulators, again, they quiet down the immune system, and I like to tell people that you have more lymphocytes patrolling your intestinal tract than you have anywhere else in your body. If you get a cold, your lymph glands swell because your lymphocytes are going to your lymph glands to be educated as to what it is that's attacking you. You have normally tons of, basically lymphocytes in the intestinal tract. And again, I go back to that analogy of the Los Angeles Police Department. Their duty is to protect and serve, and as long as they kind of keep civil order, life is good. They basically are steroid sparing. The other analogy I have is that if you have this kind of active inflammation on the interface, these are the guys who are the command and control centers. They're the colonels and the majors who are kind of telling the frontline troops where to go, what to do, how to fight. And you kind of basically are kind of dumbing down, dulling the kind of activity of the immune system with the use of these drugs. And they work, again, about 65% of patients. There's lots of potential side effects with these drugs. And I sit there in the office and they say, well, these are good drugs, and they do work. They take 2 to 3 to 4 to 5 to 6 months to do what they're going to do. And while we're doing it, you're going to end up having to be monitored very closely because they can cause anemia, pancreatitis, and blah, 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 blah. I don't really do that. But if you start listing off, they can cause anemia, they can cause leukopenia, that's low white blood cell count, they can cause pancreatitis. In this presentation, they say pancreatitis is 3%. I usually tell people it's 1%. That's where you take a healthy person and they're in the emergency room within the first 30 days of treatment with severe epigastric pain, high lipase levels, oftentimes hospitalized and not very happy with you. You can tell them that that could end up occurring ahead of time. Usually no permanent damage if that happens, but it's one of those, it's not a confidence building experience on the part of your patients when it's occurring. And then you can also occasionally get liver inflammation, which I rarely see in this day and age. We have to watch the blood test very carefully. But if you stay the course with these drugs, they work for a large percentage of patients, and they can be really phenomenally beneficial in keeping patients in remission. My concern with them long term is that they may increase risk of increased risk of infection. They also probably they decrease the lymphocyte kind of heterogeneity, that with time you become kind of like a white male 50-year-old police department. It's not a very diverse group. That our lymph systems over time become somewhat less diverse as we get older. That's part of getting older. And that's one of the reasons we don't have some of the differences in terms of the age. And we don't know what those effects are. But it's been shown in patients that were rheumatoid arthritis that the heterogeneity of the populations with chronic immunosuppression may be altered or changed, and it may have negative consequences over time, but we don't know. And again, I think these drugs are not perfect drugs, but they can be very helpful, and they're better than the alternatives. And I think as we go along, we can get smarter and have better drugs to kind of deal with these things. Again, azathioprine, 6-mercaptopurine, they're generic. They're a lot cheaper than they used to be. I hardly ever use cyclosporine. Methotrexate is primarily used in Canada. It's actually a reasonably good drug. It's not as effective as azathioprine, 6-mercaptopurine. Methotrexate can cause liver fibrosis over the long haul. And tacrolimus is not used anymore. There's a newer drug that's been released called Intibio, which I have actually yet to use, but and Andy will talk about that drug. It's an alpha integrin drug. Okay. Biologics, again, I'm going to skip over those. Again, this the natalizumab, Tysabri is the integrin drug, and that's been kind of replaced. And these are the 3 anti-TNF drugs. Again, anti-TNFs and immunomodulators and immunosuppressants, non-Hodgkin's lymphoma, probably double the overall lifetime risk of developing those. Cytosplenic T-cell lymphoma is where young, particularly male teenagers get these lymphoma that they die. There's nothing you can do for them. And the risk is probably about 1 in 5,000, 1 in 10,000. The number that have been kind of measured over the entire world is like 15, I think, total. But if those type of things happen, they're tragic when they occur. Again, this talks about different situations. Can't use methotrexate in pregnant women. If you're pregnant, you really want to keep your disease under control, and the kind of upshot is that most of these drugs can be used in pregnancy, particularly the anti-tumor necrosis factor alpha drugs. There's a whole level of concern. There are different trials that are going on. CCFA is going with a number of different partners. The hospital just bought out this research group with Dr. Wanders, and I think we'll probably be doing a little bit more, kind of getting some of these drugs. They've been trying some of these drugs for our patient population. So we have a lot of patients who have inflammatory bowel disease here in Bozeman. Again, chance of needing surgery over time, relatively high with Crohn's disease. That's because it burns out, fibrosing, stricturing, and/or abscess formation. Ulcerative colitis is just difficulty to control the disease with standard therapy. And again, it's just Crohn's disease. Basically, it's for fistula, abscess formation, any dysplasia that may occur, failure of therapy, ulcerative colitis, failure of medication control disease, intolerability of medication side effects, And there's some people who just want to go the whole route with these things, and they've been on prednisone and they want to go back on this and that. This is kind of more in the old days. And it's just awful. You get to this point where they're kind of shells of themselves with having gone through all of these different drugs. And you finally go, I'm going to give up, I'm going to have surgery. And then all of a sudden they get off some of these drugs, which have relative toxicity. And they're living with an altered body, but they've got their life back. And that's for ulcerative colitis. You get your coli out. If you live with a ileostomy, it's not the end of the world. Ileocalcium and anastomosis have their own set of issues and problems for a significant percent of patients, but they do allow continuity of the intestinal tract. Crohn's disease, generally if you have chronic Crohn's, you can have an ileostomy with some degree of trepidation. If you have surgery with Crohn's disease, the disease has a tendency to come back where the surgery was done. It has this kind of memory, comes back where it is, and oftentimes come back to the anastomosis. So one of the things we have to deal with is how do you keep these diseases from coming back if you have Crohn's disease. I've lost track of time. Where are we?
You have 2 minutes.
Oh, okay, there we go. I will finish up. Again, surgery is basically to give you the best quality of life. It is a reasonable option for many patients that have severe ulcerative colitis or Crohn's disease. And you do want to conserve your bowel as much as possible. I kind of run counter. I love my surgeons here. We have 4 very excellent surgeons. They do a good day's job. But I love some of the people who've been here have heard me say, I love the Mayo Clinic. And basically the docs, if you do these surgeries on a day in and day out basis, you just do a better job. And you don't want to have an ileocalcium anastomosis done by someone who does 1 or 2 or 3 a year. You go to the Mecca where there's someone who does them and does them on a consistent basis. Also, if you can have small incisions, people heal better, they have better outcomes, and there's a huge amount of decision-making process in terms of what to do with surgery and how to do surgery best. And you just want to be very careful when you come to that point of view, where you go and how you end up having things done. This talks about some of the different forms of surgery that are available. Risk of surgery, and again, the risk is basically that of recurrence of disease, small bowel obstruction, inflammation of the pouch, and other complications that can occur. Complementary medication, just the last thing I'll say is I'm a vitamin D Nazi. If you look at patients who have inflammatory bowel disease, their vitamin D levels are here, and the general population is here. I got interested in nutrition a long time ago. I'm not a nutritionist. Mary Jo is going to talk later today. But you can do a lot with diet. Diet is huge. And, the CCFA has this dietary thing for Crohn's and colitis patients. You have to be careful if you go online and read it because it's for flares. And that's kind of limiting kind of mechanical soft diet and this and that. But if you're healthy, you want to eat healthily, and you want to eat foods that don't have inflammatory factors, and it's this omega-3, omega-6 balance. You have to have omega-6s in your diet, but you want to be very careful in terms of what you're eating and trying to have a less, inflammatory-driven diet. It's huge. It makes a tremendous amount of difference. Also, fermentable carbohydrates tie into that as well. Some people don't digest certain carbohydrates. That may lead to bacterial dysbiosis. And then finally, if vitamin D levels are low, and probably 20 to 30% of the population walks around here with low vitamin D levels. And probably 50% of the population, if you consider 50 to be a normal vitamin D level. And vitamin D keeps your cells stuck together, keeps them from being permeable, and it decreases colorectal cancer risk, and it's huge. In my estimation, in terms of normalizing vitamin D levels, I believe normal is 50 or above. It makes a huge difference in terms of keeping people kind of in remission, in my opinion. That is not a proven form of therapy at this point. But as I said, I'm a vitamin D Nazi. I do vitamin D levels. I tell people to take vitamin D. It's amazing how some people can take 5,000, 10,000 international units of D3 a day. They don't absorb it, and they're walking around with 17, 20 their levels. So you just have to kind of stay on top of it. And even if you're taking it, you may not always be absorbing it, particularly if you've had surgery done before. And patients who have had resections or have distal terminal disease, B12 is the other vitamin. All the other vitamins don't necessarily need to worry about, but it's D and it's B12. All right, well, I'm going to kind of finish up here. I don't think there's a whole lot more that I can kind of, probiotics, I could go on about that one for a while, but you're going to have an expert on microbial flora, speak. The other thing I am is I'm a probiotic Nazi as well, and the analogy I've been using is I was on a cruise and I went to the Baltic, and we went into Helsinki, and we kind of went on a little kind of cruise around the harbor, and you see all these nice houses and these people walking along and people running. And Helsinki always has this very high level of satisfaction in terms of the lifestyle. 50% of their income goes to the federal government, which the government disperses, which kind of would be a little challenging for me. That's an aside. But I tell people that you want to have that northern Scandinavian population within your intestinal tract. You don't want Gaza Strip or the Ukraine or Western Africa. And, antibiotics can really kind of screw things up. Probiotics can help. They talk about here, and also it may be that turmeric is helpful as an anti-inflammatory. I don't use a whole lot of it because stomach upset and bowel reflux, but fish oil probably isn't of any help or benefit for most patients who have inflammatory bowel disease, particularly Crohn's. Kind of some data suggests it would be very helpful. I have a negative effect that sometimes can cause diarrhea. That's the downside as far as fish oils are concerned. Is supplements. Eating fish is probably good for you.
There's still a lot of debate about which bacteria is healthy in the way of probiotics, and there's tons on the market now. Is there a particular brand or a particular bacteria that is? Well,
I tell people that it's a wild west out there, and it's all marketing at this point. And I just say, you go to the Friendly Health food store, and Jacobus is a great guy, but there's a tendency to kind of put your arm around you and say, here, I've got this and that, and this probiotic, and before long, you're spending X number of dollars. And naturopaths are not bad people. In fact, they've helped a lot of my patients who have inflammatory bowel disease. There's this tendency to kind of do a little selling along the side in the marketing, and you have to see through the marketing. You have to read labels when you buy food. Fructose is a bad sugar. You have to end up kind of stepping back and saying, who's benefiting from this? What is my benefit? And I basically, what I do is I basically say, high quality yogurt, Danone is not yogurt. Anything has fructose in it is indefensible in my mind. That's me, okay? That's not necessarily proven. But fructose it kind of mainlines into palmitic acid, and it kind of goes right into your liver. It does all sorts of inflammatory things. So fructose is not good. And I'm heavily into Nancy's yogurt, brown cow, or the better quality yogurts. And there are differences in yogurts. It's the difference between Bud Light and Bozone Amber, or maybe kind of having a real craft beer. There's craftsmanship, and you want to have a craftsmanship type yogurt, or do it yourself. And I'm also heavily into kefir. I think kefir is a phenomenally beneficial form of nutritional supplement. Again, we've gone off track in our society because we have this custard-style yogurt, sweet. If you add sweeteners to it, is to you change taste perceptions. You eat more sweets, more carbohydrates. Carbohydrates can be inflammatory in the long run. But what you want to do is you want to end up getting back more to the natural forms of food, and most kefirs are actually pretty good in that respect. You get up to 100, 150 billion organisms with a lot of kefir, depending on how much you end up consuming. You get 60, 80 billion at least with most forms of yogurt. And you've had 10 trillion bacteria, or 10 trillion bacteria in your intestinal tract, and you have 1 or 2 billion bacteria, probably not doing a whole lot. There are differences between bacteria, like Lactobacillus GG culturale seems to have some specific properties that are beneficial. Align is Bifidobacter infantis. That's Procter & Gamble product. Probably a lot of marketing there because it doesn't make any sense in terms of what their data is when you look at it. So I don't have any answers in terms of what's over the counter. So I say go back to the food sources, eat high quality yogurt or kefir, and get to know your less processing from the farmer's field. Read the Omnivore's Dilemma. You'll never eat anything again. What? I'm sorry, go ahead.
Can you overdo vitamin D?
Oh, you can overdo vitamin D. Yeah, you rarely can get into toxicity. I've seen it once. It's a fat-soluble vitamin, so it will build up in your body, and you can get liver inflammation from too much vitamin D. So that's the paranoia about vitamin D. But again, I'll make one last comment. We were not meant to live this far north unless you were a Viking. You lived on the, on the side and ate fish, because unless you're walking around naked all summer long, that's the other thing I'll say. You'll never get enough vitamin D living this far north. And there's not enough vitamin D in our diet. There's no natural sources of vitamin D in the diet unless you eat fish. Milk is what you have in front of you is vitamin D fortified, but the amount of vitamin D within your milk is minimal, being considered. The RDA is 400 international units, but that's insufficient for probably 50% of the population.
I've heard things about vitamin lamps, lighting.
Not knowledgeable about those. Again, you have to have 50 nanometers. It's a specific wavelength to hit your skin to produce vitamin D on your skin. It's phenomenally interesting, how vitamin D is manufactured or not manufactured, as the case may be. So I assume that these lamps have a 500 nanometer wavelength. That's what they're kind of coming into contact with your skin. But it's not a very effective way. When your dog goes out and lies in the sun and it's hot out there, the dog is actually getting sunlight hitting their hair and it's creating some vitamin D on the surface. They have no kind of surface skin, and they lick it off. So there are other ways of getting vitamin D. But it's a critical micronutrient. It's become a trendy micronutrient, but there's reasons for it. And you have, the Mayo Clinic came out 7, 8 years ago. I say this all the time. They said, this is a fad. There's no data to support all these claims for, blah, 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 blah. And then about, 8 months or so ago, they came out with a monograph saying, the data supports most of the what's being said about vitamin D. And I also had been on a educational thing with Walt at the Mayo School of Public Health, and this is about 15 years ago. And Walt said to me, he said, we've been testing our vitamin D levels in Boston. They do the and he said, we're finding a lot of people have very low vitamin D levels at the end of winter. And it's like this little click light bulb. Never heard of that before, because we never thought of vitamin deficiency. That can be vitamin deficient, and you kind of see how, when you start doing vitamin D levels around here, it's just incredible. People are low. Well, I'm taking up more than my time.